Welcome everybody to the ISN educational webinar. The topic of today is the update of the CKD-MBD KDIGO Guideline, which will be released very shortly now. My name is Marc Vervloet. I'm a nephrologist in Amsterdam, the Netherlands, and I'm the director of the Kidney Research Unit. And in addition, I have been committee member of the KDIGO Guideline on CKD-MBD. The formula of today is that things important to know is that everybody will be on mute except the speaker. This is to avoid background noise. This is for you good to know. And we will follow with a presentation by the panelists, which I will introduce to you shortly. And after this presentation, which will take about 20 to 25 minutes, you will have the option to ask questions. Well, actually, we will address the questions afterwards. And in the meanwhile, you have the possibility to post questions in the question box. After the presentation by the panelists, there will be a short poll consisting of 3 questions. And before we go to the presentation, I will shortly introduce the panelist, which is Dr. Block from Denver, Colorado. Dr. Block has been involved in many epidemiological and clinical translational research related to CKD-MBD for 2 decades now. He also is a member of the KDIGO Guideline on CKD-MBD, both in 2009 and 2017. And he has served on the steering committee of several randomized controlled trials related to this topic, which includes the EVOLVE trial and the phosphate normalization trial. As mentioned, he is director of the Clinical Research Unit at Denver Nephrology, Colorado. So now we continue by the presentation by Dr. Block. So Dr. Block, please.
Thank you, Marc. It's a real privilege and honor to be here, and honestly, it was quite a privilege to serve on the Workgroup committee for the update on the management of CKD-MBD. And so I will share with you today this clinical practice guideline update that, as Marc mentioned, will very soon be in the public domain. And let me start by telling you that the mission of KDIGO is to improve the care and outcomes of kidney disease patients throughout the world, and this was an important aspect, and it's not to forget that the guidelines that we create have to be relevant to patients with kidney disease all over the world, and this definitely played a role in our guideline development as we considered the quality of evidence and the level of evidence that we had to deal with. And honestly, KDIGO, in my opinion, has been a tremendous advance for our field and has resulted in a much more uniform approach to how we take care of patients all over the world with complex disease. This slide is meant to show you, hopefully you're seeing the whole slide. This slide is meant to show you how the KDIGO approaches the clinical practice guideline development process and the revision process. And it's important because this is, I think, the first guideline that has undergone this full cycle where we developed the clinical practice guideline. It was implemented, the original MBD guideline in 2009. It was implemented, presented to the world, and then over a period of time, 6 to 7 years, though many of us conducted research in the field, met again recently to discuss another controversies conference with regard to what have we learned with regard to MBD management, decided that there was enough new information that warranted a revision or an update, held another controversies conference, and what you're seeing today is the sort of full circle back to the updated clinical practice guideline. The controversies conference that was held was meant, and this is just to let you know, and this is an important aspect of this, this was meant to establish what aspects of the previous MBD guideline that we felt had enough new evidence that would warrant an update to the existing clinical practice guideline. And I think in order to understand that and put it in context, you have to remember that the original controversies conference with MBD was held in 2005. This is where we actually came up with the term CKD-MBD, and with this cartoon that describes the focus of the KDIGO effort in this area, which is not focusing on individual lab abnormalities or specific bone abnormalities, or even this surrogate of vascular calcification, but focusing our efforts on the combined clinically meaningful endpoints of patient events, including cardiovascular events, fracture events, and of course, mortality events. So in 2005, we held this initial controversies conference. And then, as I said, we completed this circle of implementation, research, and then new controversies conference, where we wanted to identify the areas that potentially needed revisions and provide a roadmap to a new committee that could be used for updating the guideline. And that's how we ended up where we are today. So in 2013, the second MBD Controversies Conference was held. There were 74 people from around the world. 19 different countries, I think, were represented at the conference. At that conference, we tried to have experts in all areas of cardiovascular, nephrology, pediatric, transplant experts. And we identified, well, we broke out into 4 different areas to discuss whether or not these topics had enough new information to warrant an update to the 2009 guidelines. And those included areas of bone quality, issues related to calcium and phosphate, issues related to vitamin D and PTH management, and the surrogate of vascular calcification, which was identified as one of the key components of CKD-MBD. So in 2013, the result of that second controversies conference was that that group felt that there was enough new information for a selective guideline update. And I put this slide here not for you to read, obviously, any of the particulars, but what you see sort of laid out in landscape form are all of the KDIGO-MBD guidelines, and highlighted for you are the select guidelines that the controversy conference members decided should be updated. And this is one of the key points I want you to walk away with, is that this was not a complete revision of the 2009 guidelines. It was a very selective update based on the controversy conference members' belief that these areas had enough new evidence to warrant a discussion of by the work group. So I've already been asked by many people certain things that we did not address. And the bottom line is I will share with you what we did address, but we did not review the entire MBD 2009 guideline. So what I'm going to share with you now, it will be in press in Kidney International, I believe this month. Actually, wait, May 2017 is last month. It should be this month or next month. I don't have an exact date, but I can tell you that it's imminently available for public review. It has already undergone a public comment period at the end of 2016. Hopefully you participated in that process. The work group members reviewed those comments and modified the draft guideline into this final guideline, which I'll share with you now. So what I will share with you is in fact a final guideline. What you'll see in the Kidney International supplement coming soon is a nice summary table that lists a comparison of the 2009 recommendations and how those recommendations have been changed in 2017. Again, it's not an entirely new guideline. It is an update to the guideline we previously wrote. So just a quick to point out. So the guideline committee consisted of our chairman, Marcus Kettler from Germany, and Mary Leonard from Stanford. And the work group members are outlined for you. And I had the privilege of being on this committee and working with these wonderful people, honestly, over a period of almost 3 years. Since the Controversies Conference and the work group was convened, we've been working quite diligently to put together this final draft. And Dr. Vervloet was a work group member with me. So together we can answer your questions, I think, quite nicely about the MBD guideline. All right, so the process, I won't go into great detail about the process that we followed, but it followed a very rigorous process where the evidence was reviewed. The questions were outlined in advance. The evidence review team, which in this case was led by Karen Robinson and her team at Johns Hopkins University, followed a very strict criteria for looking at randomized controlled trials. We have followed the same recommendations as the 2009 work group, in which publications or clinical trials had to have a minimum of 25 patients per arm. Patients had to be followed for at least 6 months. And we then follow the grade system, whereby the quality of the evidence was rated both on the level of evidence and the quality of the data itself. So at the end of the day, again, I'm not going to go into this in great detail. We come up with both a numeric level 1 or level 2 a recommendation, which generally reflects either we should or we could statement, and a numbering system or lettering system of A, B, C, D, which reflects the strength of the overall evidence, with A being the highest and D being the weakest. So the strongest level of evidence could be 1A, and the weakest total could be 2D. Let me let the computer catch up for 1 second and emphasize again for you, this was an incredibly important component of our discussions, that we are treating and making decisions about patients. We're not really making decisions based on what happens to laboratory values. And while this may seem fairly obvious, it is quite important when you start looking at the actual evidence base for what happens at the level of patient-centered outcomes, as opposed to what happens at the level of biochemical outcomes. And this certainly influenced our ultimate decision-making. It's important for everyone to realize that the work group recognizes there are very large areas with an evidence gap. Many of the areas for which we had research recommendations in 2009 remain still with research recommendations. There are very few, relatively very few randomized controlled trials upon which we could base our new evidence recommendations. And as I've said a couple times, please recognize that there are existing guidelines for which no new evidence were available, and so they were not reviewed. And these include important topics such as the issues related to the PTH assay and how we deal with that. So these were not part of the 2017 guideline updates. So let me tell you, this is the general outline of what I'll talk about now. We'll go through topics. We're not going to talk about each of these because not all of them were updated, but this is the general guideline topics that we will follow over the next 15 or 20 minutes. Let's start with bone quality. One of the important things, I'm sorry, it's a little bit challenging for me given that I randomly see things on my screen, so I apologize. So on the area of bone quality, as you know, previously the KDIGO guideline had suggested that bone mineral density testing was not to be performed routinely, and I think it's a significant update that the new recommendations suggest that patients with stage 3A through 5D who have evidence of MBD or have evidence of risk factors for osteoporosis, that bone mineral density testing should be performed if it will impact treatment decisions. Now, this is a approach that this work group took with some regularity, and I think that it's something for everyone to acknowledge, that we recognize that there's a breadth of difference of opinion about whether or not a bone mineral density might affect your treatment decision, depending on where you are in the world and what you have available to you and your comfort with using some of the anti-resorptive therapies. However, what we did want the world and the community to recognize is that, in fact, in the previous guidelines where it suggested that the BMD did not predict fracture risk particularly well, the new evidence generated since that time does in fact suggest that bone density predicts fracture risk across the entire spectrum of patients with CKD. And there have been several publications that we cite, four or five in the guideline update, that support this finding that bone density does predict fracture risk. And I think hopefully you're seeing a meta-analysis in patients both with CKD and non-CKD, non-dialysis and dialysis dependent, which both suggest that bone mineral density actually predicts fracture risk across this spectrum. Now, it performs best in patients with stage 3A and 3B, and there's less data in patients with stage 4 and stage 5, but there is data in both dialysis patients and non-dialysis patients. So this is a substantial difference. So in our opinion, you should perform bone mineral density testing if it will change your management of disease. And for many of us, it will. Now, related to bone quality has to do with the topic of doing a bone biopsy. And the previous guidelines suggested that you should only perform bone biopsy in various settings and listed 4 or 5 settings where that would be reasonable. The new work group felt, honestly, that it is completely reasonable to perform a bone biopsy if knowledge of the underlying renal osteodystrophy histopathologic diagnosis would impact your treatment decisions. So this is important because it no longer restricts when getting a bone biopsy would be reasonable. And this is probably most important clinically in the setting of using anti-resorptive therapy in patients with CKD. Previously, the guidelines suggested that you should get a bone biopsy, or it would be reasonable to get a bone biopsy before you used anti-resorptives. The new work group felt that the data on the efficacy of anti-resorptive therapy in CKD was quite reasonable, not robust, and that there was no actual evidence of harm, despite our concern about inducing adynamic bone disease. There actually is no evidence of this. And so the guideline was changed to suggest that if it would actually change your treatment decision, then it's reasonable to get a bone biopsy, but it's certainly not necessary before instituting therapy. By the way, nobody on the work group wanted to diminish the importance of the bone biopsy. We feel like this is an incredibly useful and important tool to understand disease, but that it didn't need to be restricted to these certain settings and didn't need to be done before enacting treatment for bone disorders or for reductions in BMD. Now, let me move on and talk about serum phosphate for a bit, because this is, again, an important and changed topic. So the previous guidelines suggested that we should keep serum phosphorus in the normal range in patients who are not on dialysis, and that in dialysis patients, we should lower elevated phosphorus towards the normal range. There are 2 new aspects to this guideline that are important. The first is that we now overtly recommend that you need to base your treatment of MBD on serial assessments of calcium, phosphorus, and PTH considered together. And I'll show you a slide in just a minute as to why that is, but not in isolation. So 2 components here. It should involve multiple values over time of each of these, and they should be interpreted in the context of each other and together, because they are so intimately connected. So we don't prioritize phosphorus over calcium or PTH over phosphorus, or they need to be interpreted together and over time. And the second is quite important, that we have modified the recommendation with phosphate to suggest that we should lower an elevated serum phosphorus towards normal in all stages of kidney disease, but that our evidence base for preventive therapy, for maintaining phosphorus in the normal range, is actually quite weak. And I'll show you one quick slide on the a randomized controlled trial that supports that, that recommendation. So the slide you see in front of you comes from an analysis that I participated in dialysis patients, where we created separate phenotypes that were mutually exclusive of PTH, calcium, and phosphorus without any overlap in an individual. And what we showed, and I don't expect you to spend too much time on this, but what we showed is that, in fact, these factors are not independent of each other, and that when you put people into specific phenotypes of groups of calcium, phosphorus, and PTH, it absolutely leads to a progressive improvement in identification of cardiovascular risk, cardiovascular hospitalization, or death, and that treatments that affect only one of these parameters positively might negatively affect others and needs to be incorporated into your decision making. For example, Active vitamin D absolutely is effective in lowering PTH, but as you know, it can raise serum phosphorus and probably raise FGF23. Calcium phosphate binders can lower phosphate, but they might affect serum calcium values, and they also might affect FGF23. And the recommendation is that you put these together as you construct a treatment regimen. The second important aspect of the phosphate change has to do with this issue related to using phosphate binders as preventive therapy to maintain a normal phosphate level, as opposed to treating an elevated phosphate. And again, we have data from the phosphate normalization trial, so-called PNT, where I had the privilege of working with a lot of wonderful investigators around the world. And we tested in patients with non-dialysis CKD, 3 different phosphate binders compared to placebo. And very briefly, what we demonstrated was that while they did have some effect on serum phosphate, they also resulted in progression of calcification versus placebo. So at the end of the day, it was very unclear what the net benefit was in terms of adopting this preventive strategy approach. And the work group felt that we did not have data to suggest that we should maintain serum phosphorus, but in fact, we should treat an elevated serum phosphorus. And it's important for you to recognize that the work group acknowledges that there may in fact be benefit in maintaining serum phosphate in the normal range, benefits related to reduction in phosphate intake and benefits related to FGF23 reduction, but the data does not support the use of phosphate binders to accomplish this. And it's clearly an area where there's an evidence gap between what we think may be optimal and what we can demonstrate in randomized controlled trials. With regard to serum calcium, and by the way, I know that I'm going fast. We have quite a few guideline updates that I want to share with you, and I want to leave a good amount of time for questions. So with regard to serum calcium, another important change is that the previous guideline recommended maintaining serum calcium in the normal range, and the new guideline is very different. It suggests that we should avoid hypercalcemia. And by the way, I'm not going to talk about pediatric guidelines here today, but in adults, we should avoid hypercalcemia. And what the intent of this is to acknowledge that current therapy with calcium mimetics quite often results in asymptomatic, mild hypocalcemia, as demonstrated in this figure, hopefully, that you're seeing from the EVOLVE trial. That calcium mimetics induce this mild hypocalcemia that is almost always asymptomatic, and that this does not warrant intervention to try to bring serum calcium back up into the normal range. The work group felt very strongly that we are not suggesting that you not treat severe hypocalcemia or profound hypocalcemia or symptomatic hypocalcemia. We all acknowledge that's important. But the mild asymptomatic hypocalcemia induced by calcium mimetics probably does not warrant therapy with calcium. And that gets to a future guideline that's important that we also updated. So the new guideline suggests avoiding hypercalcemia and does not mandate maintaining serum calcium at the lower end of normal. Now, one of the strategies that was previously recommended to maintain a normal serum calcium was the use of a dialysate calcium between 1.25 and 1.5 millimoles per liter. And that recommendation has not changed, but it's important. I put it in the slide deck because the level of the evidence to support this particular dialysis calcium concentration has improved. So you see it's gone from a 2D to a 2C. And that's because there has been pretty good data, randomized controlled trial data at the higher end. So you see in front of you one trial that compared a dialysis patients at a 1.25 calcium versus 1.75. And importantly, not only did measures of bone histomorphometry improve in the lower calcium, in the 1.25 calcium group, the progression of calcification was reduced, coronary calcification. So the work group felt that there was even more evidence to suggest that dialysate calcium concentration should be between 1.25 and 1.5. We have no new evidence really at the low end other than observational data suggesting that going below 1.25 calcium is associated with harm. So again, that didn't rise to the level of the quality of evidence that we could put in the guideline, but we do acknowledge it in the rationale for our decision making. All right, here's a somewhat new work group recommendation in the guidelines, and that has to do with when you should institute phosphate lowering treatment. And I want to point out to you this term, phosphate lowering treatment, because the work group very specifically wanted to move away from the term phosphate binders. We acknowledge that there are other phosphate lowering treatments that are effective, and future phosphate lowering treatments that are non-binders that are likely to be studied in research. So this includes dietary interventions, this includes potentially phosphate transport inhibitors, this includes things that might affect passive phosphate transport. So our terminology is now phosphate lowering treatment. And our recommendation is that you base your decision on whether or not to institute that therapy on a progressively or persistently elevated serum phosphorus, meaning not a single value, and particularly in stage 3 through 5, not on dialysis, that the data would suggest that the patient needs to demonstrate that things are actually getting worse or it's severe before you institute therapy that might be associated with harm. As I showed you, the only real good randomized controlled trials in these populations, and there have been several, have shown almost no benefit and some harm. So this evidence gap is important and influence our decision making. This topic is a particularly striking change for how we take care of patients, and I want to bring your attention to this quite importantly, 4.1.6. And what this says is that in adult patients in whom you are going to use phosphate lowering treatment, we suggest restricting the dose of calcium-based phosphate binders. This is a substantial change from the 2009 guidelines, in which we said in certain circumstances you may want to reduce calcium exposure. The new evidence base very strongly supported, and you can see this is a 2B recommendation, restricting the dose of calcium. Now, we don't have a dose for you. We don't tell you what the upper limit is because there's no good evidence to tell us that information. So, but we do acknowledge that there is an apparent upper limit for calcium exposure across the entire spectrum of CKD that is associated with harm, and that we need to restrict calcium-based phosphate binder use. And this data, quickly, I'll show you, has come from clinical trials, randomized controlled trials in patients on dialysis, as you see here, in which Dr. Diorio showed that in new dialysis patients, when you compare calcium to sevelamer, both arrhythmic events and cardiovascular mortality were improved with sevelamer as opposed to calcium over a period of 3 years. And in non-dialysis patients, this is a sizable number of non-dialysis patients, again, comparing calcium to sevelamer, that those patients treated with sevelamer had improved outcomes with regard to mortality and or starting dialysis. Now, I should point out, these are not placebo-controlled trials. These are comparing two active therapies. And as I mentioned earlier, our recommendation in non-dialysis patients is that you reserve phosphate-lowering treatment for those patients who have progressive and severe hyperphosphatemia and have a phosphate above the upper limit of normal. But if phosphate-lowering treatment is used, there's a very clear strength of evidence to suggest non-calcium has some benefit and that we should restrict the total dose of calcium. I'll very quickly show you there have been 2 meta-analyses of this topic, both comparing calcium to non-calcium phosphate binders. Dr. Jamal's meta-analysis in Lancet a few years ago demonstrated in aggregate a 22% lower mortality risk associated with sevelamer. And a subsequent meta-analysis published last year by the Cochrane group again shows a mortality benefit when you look at non-calcium, in this case sevelamer, relative to calcium in patients with CKD. Acknowledging that the strength of evidence, we continue to need more randomized controlled trial data, but in aggregate, the evidence is consistent and favors non-calcium phosphate binders. The final slide here, I will just try to quickly go over, is just pulling out a all-cause mortality from the meta-analysis of Patel, showing you that there's a substantial survival benefit associated when you compare sevelamer versus calcium. Let me move on now and talk about dietary phosphate intake, because this guideline changed very subtly, but in an important way. So previously we suggested limiting dietary phosphate intake as a treatment method, and we continue to endorse this, but I encourage you to read the rationale, because the strength of this endorsement is honestly quite weak. The data suggesting that dietary phosphate intake lowers serum phosphate is not robust. And what we did add is that the source of phosphate is now acknowledged to be an important contributor to the net effects of harm with phosphate intake. And so we now have quite a bit more information on the biologic effects of vegetarian versus animal protein sources, and the effects of phosphate-based food additives. And so the recommendation now suggests that limiting dietary phosphate intake is a component of therapy, but you should consider the source quite carefully when you make recommendations. And some of this comes from excellent work by Sharon Moe, as you see here, showing that on the same total phosphate intake, patients with CKD who are put on a vegetarian phosphate source versus a meat phosphate source had a reduction in their serum phosphate, and a reduction in their PTH, and a reduction in their FGF23. So the total phosphate intake remained the same, but when it comes from a vegetarian source, the biologic effects are quite different. And similarly, there is a growing amount of data on the hidden sources of phosphate that are put into foods to enhance their shelf life, how long they live on the shelf, their preservatives, and their palatability. So we think this is an important new aspect to phosphate management that we need to consider in our care. Let me move on to treatment of PTH, because this is obviously a topic of great interest. This is a very substantial change from the past. And so I want to point out to you that we suggest that patients with CKD who are not on dialysis, who have progressively rising PTH and persistently above the upper limit of normal for the assay, be evaluated for these factors, including we added high phosphate intake to this list and vitamin D deficiency. Now, it's important to recognize the term progressively rising or persistently above the upper normal limit, because the previous guideline simply said if it was above the upper limit of normal, and this work group felt strongly that some degree of secondary hyperparathyroidism is in fact adaptive and important, and our goal should not be to reduce PTH below or back to normal, but that there is a safety issue related to treating PTH in stages 3 through 5. And as you see on this slide, the rationale that this adaptive response is important. And so we've added this term persistently and progressively to emphasize that not all PTHs that are elevated above normal should be reduced. Now, one of the biggest changes in the guideline recommendations has to do with the use of calcitriol or active vitamin D analogs for these individuals. So our new guideline 4.2.2 suggests that in patients who are not on dialysis, that calcitriol and vitamin D analogs should not be routinely used. Now, we all agreed that these medicines are indeed effective at reducing PTH, and they are reasonable when those patients have severe and progressive hyperparathyroidism, that calcitriol and vitamin D analogs be used, but that they should not be routinely used. And the rationale for this, again, is a balancing of net benefit with net harm. And there have been two very important randomized controlled trials that have been conducted since 2009 that demonstrate some biochemical benefit with regard to PTH, but some harm with regard to other factors. And the first of these is the PRIMO trial, which showed effective PTH reduction with pericalcitol. However, What it also showed is that average calcium went up by 0.3 milligrams, average phosphate went up by 0.23 milligrams compared to, and didn't change in the placebo group. So the vitamin D increased calcium, increased phosphate, and hypercalcemia was observed in almost a quarter of the patients. And there was no effect on the cardiovascular size, structure, or function. A similar well-done clinical trial by Dr. Wang, looking at the same patient population with the same trial design, similarly showed that when paracalcitol was used to lower PTH, it resulted in hypercalcemia and an elevation in serum phosphate. So the work group felt fairly strongly about this, that we should not routinely use calcitriol or vitamin D analogs and reserve their use for patients with severe and progressive SHPT. This is certainly going to be one of the more controversial of the guideline updates. Let me move on because I acknowledge I want to leave us more time for questions, and we have a few more things to discuss. I apologize, my own slide deck seems to be a little bit behind. So let me talk about lowering PTH in dialysis patients, and this is going to be a little confusing, but the guideline, the new guideline is what you see, 4.2.4, and we suggest that in patients with stage 5D who require PTH lowering, that calcimimetics, calcitriol, or vitamin D analogs, or a combination, are all appropriate. Now, there was a very lengthy discussion about whether or not calcimimetics should be recommended as the first-line therapy, as opposed to sort of equivalent first-line therapy with calcitriol and vitamin D. And I will just briefly tell you why that is for the sake of time. As you all are aware, the EVOLVE study was conducted, I believe it's the largest randomized trials in dialysis patients, and the primary endpoint was not statistically significant with regard to the cardiovascular outcome. And you see that on the left hand of your slide. And the work group endorsed that the primary outcome was, we don't use the term negative, but it was not positive, all right? However, the work group also acknowledged that there is a substantial body of evidence suggesting potential benefit of calcimimetics, and that includes the age-adjusted analysis, which you see on the right-hand side, which did show a significant benefit in an age-adjusted analysis associated with cinacalcet. And importantly, secondary papers that have been published demonstrate that there are subgroups who may have particular benefit. As you see here, those patients who are over the age of 65 had a substantial improvement in the primary composite endpoint, while those less than 65 did not. I'm not going to spend time on this. We can take the questions, I'm sure, but when evaluated in terms of use of medicine, either commercial medicine or getting a parathyroidectomy or getting a kidney transplant, and you censor at those events, all of these analyses suggested potential benefit, significant benefit associated with calcimimetics. So the rationale for our guideline and the way it was worded was quite challenging to accomplish. What we acknowledge is that although EVOLVE did not meet its primary endpoint, the majority of the work group were reluctant to exclude the potential benefit of calcimimetics. And so we didn't prioritize any of the PTH lowering treatments. We finally adopted a sort of alphabetical approach to the recommendation, but acknowledged that each of them are appropriate first-line therapy. I should point out that, again, since the 2009 guideline, there have still yet to be any randomized controlled trials looking at patient-level outcomes with calcitriol or vitamin D analogs. And so it was challenging for us to prioritize one over the other. All right, so I'm getting near the end. Let me just sort of summarize for you the key messages from the guideline updates. The first is that prospective studies looking at bone mineral density testing in adults with chronic kidney disease do suggest that they predict future fracture risk, and we suggest getting bone mineral density testing if they will impact your treatment decision. we think it's important to emphasize the interdependency of calcium phosphate and PTH, and that decision-making should involve all of them simultaneously, not prioritizing one over the other. We now use the term phosphate-lowering therapy, and we recommend it be used in patients who have progressive or persistent hyperphosphatemia, not just trying to prevent hyperphosphatemia, and that new evidence suggests that excessive exposure to exogenous calcium, in fact, is harmful across the entire spectrum of chronic kidney disease, regardless of other risk factors, and we should restrict calcium intake. We believe it's reasonable to limit dietary phosphorus intake and pay particular attention to the source of dietary phosphate. As I showed you, we acknowledge that randomized controlled trials of calcitriol and its analogs show, while they do show PTH efficacy and reduction, they also demonstrate potential harms, and we recommend against the routine use in chronic kidney disease. And while there was no recommendation about cinacalcet as the first-line therapy, we acknowledge that the majority of the work group wasn't willing to exclude a potential benefit of that treatment choice. Let me end there. I want to thank, before I end, let me thank the KDIGO staff. It has been tremendous. Michael, Danielle, Tanya, and let me point out specifically Dr. Vervloet and Dr. Wheeler, from whom I borrowed many slides for today's presentation. Let me stop there, Marc, and I'm happy to take questions.
So thank you very much, Jeff, for this wonderful and excellent presentation, which you, in not even half an hour, summarized all that has been changed. Now we will give the opportunity for everyone to post questions in the question box. We already did receive some questions, which we will address in a minute. In the meanwhile, I hope that the people at the central control desk can bring us to the quiz. We have 3 short poll questions for you to get the discussion started.
Yes. So this is Kelly Hendricks with the ISN, and indeed we normally had 3 quick poll questions to get the discussion started, but Marc, since I see there's already quite a few questions already, and given the limited time and the numerous amount of participants at this webinar particularly, which I assume means they want a lively Q&A session, I propose perhaps that we ergo the quiz this time and let you just go straight into the Q&A. Is that okay?
Yes, of course. That's wonderful.
Okay.
So we have quite a couple of questions, and before we can tackle these individually, I want to make a short comment on it. So some of these questions are quite specific clinical questions, and I think both Dr. Block and myself need and will be quite specific when the answers are based on the guidelines. But quite some questions actually are, well, open for discussion, also for Dr. Block and myself. So the first question is, can oral bisphosphonates be given to end-stage renal disease patients who have osteoporosis? Jeff, do you want to start off?
Oh, good. An easy question first. Thank you, Marc. So it's an excellent question, and I think let me give you the evidence-based answer. Is that there are no randomized controlled trials, of course, looking at the use of bisphosphonates for the treatment of low bone mineral density in patients on dialysis. So my response to you is going to be, and I'm curious to see Marc's response, a personal opinion based on my assessment of the data. The answer is that there certainly are circumstances where bisphosphonate therapy or anti-resorptive therapy is appropriate in patients on dialysis, in my opinion. And I think that this is one of those areas where personally I think the use of bone biopsy is very important, because, as you know, PTH, the assay, is not particularly sensitive or specific. There was an excellent piece of work by the KDIGO, sort of a subgroup of KDIGO years ago, that looked at the precision of PTH in predicting underlying bone remodeling based on bone biopsy specimens, and it's quite poor. It really is quite poor. So, which suggests that our ability to tell who has high turnover bone disease and who has low turnover bone disease based on a PTH is not good. I happen to be a strong advocate for the combined use of PTH and alkaline phosphatase in trying to help determine the underlying bone remodeling disorder. But I want to point out, this is important for everyone to acknowledge, that the hip fracture rate, at least in the United States, over the last 15 years in dialysis patients has been increasing dramatically. It has approximately doubled. The hip fracture rate in the dialysis population has approximately doubled in the United States. And if you look specifically at who's fracturing their hip, it is people with risk factors for osteoporosis. So my opinion is that there absolutely is a role for anti-resorptive therapy. As you know, the dose has to be modified, and you have to be have some acknowledgement that of the risk of hypocalcemia. So the therapies we have available are bisphosphonates and denosumab. As you know, teriparatide is available, but is not considered an anti-resorptive. It's a bone formation medicine. So I do think there's a role, and I do personally believe that this is why bone mineral density testing is important. If you choose to use an anti-resorptive therapy in ESRD, I suggest that we check bone density and we follow it over time to make sure that our therapy is having the intended effect. Marc, I guess that's my response, and I'm curious to see you.
Yeah, I completely agree. Well, the difficulty usually would be to actually establish the diagnosis of osteoporosis. So this is important, an important change, as you alluded to, compared to the 2009 guideline that we now indicates that there may be a risk prediction value of performing a DEXA scan, which indicates fracture risk, but actually does not indicate what type of bone histology you will see. But the reason for not strengthening so much the importance of bone biopsy is that if you consider bone biopsy to be an absolute requirement before using bisphosphonate or other anti-resorptive therapy, we might we might withhold important patients to important treatment to some patients. I think for the sake of time, we must proceed to the next question because the numbers of questions are rising. So the next question is there any reason to consider one phosphate binder to be superior over the other with respect to cardiovascular risk? Well, let me start off to relieve you for a bit, Jeff, if that's okay.
Sure.
So phosphate binders, as has been presented just a minute ago, usually have been compared to other phosphate binders, and the most easy to assess endpoint has been mortality. For instance, the two studies by Delorio indicating that the use of calcium-based binders appear to have a higher risk for mortality. And as we all know, most frequently mortality risk parallels cardiovascular risk. So when comparing phosphate binders, there appear to be either a benefit of non-calcium containing binders or some dismal effect of calcium-based binders. So do you agree, Jeff?
I absolutely do.
Okay. So the next question is an interesting one, which is how to treat patients with CKD stage 3 and 4 who have normal calcium, phosphate, but a raised PTH. Well, actually, this brings us to an issue which may not have been addressed yet, which is the potential of PTH resistance. So PTH can rise, as we discussed, in stage 3 and 4. And to some extent, this can be considered to be adaptive because PTH is a phosphaturic hormone. But in addition, there also most likely is the feature of PTH resistance. And this question may address to people who have PTH resistance. So please comment.
Yeah, Marc, I think you raised an excellent point, and I think the work group as a whole really endorsed this notion that PTH elevations, certainly some component is an adaptive response, and that modest PTH elevations in CKD are in fact an appropriate response to the reduction in GFR to help maintain normal phosphate balance, or at least try to get back towards normal phosphate balance. I think one of the things we didn't really discuss, and the KDIGO guideline workgroup did not look at as an update, but as important is the topic of vitamin D insufficiency or deficiency. It is in our guideline recommendation that this be addressed or at least evaluated in patients with progressive or rising PTH. And I think that's an important component to answer the question. I think that maintaining vitamin D sufficiency is likely to be an important component of maintaining an appropriate level of PTH adaptation. And I also think that looking at phosphate intake and the variety of phosphate sources will be an important component to that as well. I think that we have not done a good job of understanding how phosphate intake may be driving hyperparathyroidism independent of what's happening to serum phosphate. We now know that phosphate intake per se affects FGF23 regardless of serum phosphate effect. So I think that there are components here that are important to manage PTH that are not medication driven.
Yeah, this brings up a complicated issue, because in the study you performed, Jeff, you showed that there apparently is a difference in controlling phosphate by either using phosphate binders or, as you just mentioned, the use of phosphate restricted diet.
Yep. It's quick. I think there's no evidence right now, by the way, as you said, there's almost no evidence that would support the use of phosphate binders in CKD patients who do not have elevated phosphate. So far, that evidence doesn't exist.
Yep, that's okay. So the next question is if we can be a bit more specific, I guess, about when actually to start cinacalcet if PTH is high or rising. So.
Well, unfortunately for whoever asked the question, everyone would like an answer to this, but we adopted a position that number varies around the world. As you know, for example, it's quite different in Japan than it is in the United States. And I think that there is not a single target PTH for which we have said, this is the threshold above which everyone would agree you need to start therapy. So we have not specified a particular PTH threshold, and I think that's why it's important to put in your decision making what's happening to the alkaline phosphatase, what's happening to the phosphate, and what's happening to the calcium. When you look at phenotype data, there's no question that risk increases dramatically if someone has an elevation in all three of those parameters, and this probably should influence your decision making.
Yeah, I completely agree. And although this was not a topic of the KDIGO update guideline, it is important to remember that sometimes hyperphosphatemia may not be due to the gastrointestinal uptake, but actually due to release of phosphate from bone. So in the setting of therapy resistance or assumed therapy resistance to phosphate binder therapy, it's important to keep in mind that controlling PTH might be very helpful in controlling phosphate.
Yeah, I completely endorse that, Marc.
Okay. Did the new guideline make any recommendations for the treatment of vascular calcification other than avoiding hypercalcemia or treating hyperphosphatemia? So is there any more specific therapeutic measure available to target or to treat vascular calcification? So this is, well, I guess a very important and possibly also difficult to answer question. Can you?
Well, it is a really important question, but actually easy to answer because at the 2013 Controversies Conference, the attendees evaluated whether or not they felt there was sufficient new evidence to warrant an update to this guideline area, and they did not. So I think everyone acknowledges that vascular calcification is likely to play an important role as a surrogate for CKD-MBD, but unfortunately, there simply isn't an evidence base to guide treatment recommendations based on vascular calcification. This particular guideline update does not update the topic of vascular calcification.
Yep. Okay. So the next question is, and we have only a few more minutes left, and it's important for the attendees to know that we will actually really stop at 4, but you have the opportunity to post questions even after this webinar. The next question is about what about iron-based phosphate binders? And several recent papers indicate that the phosphate binding potency of the novel iron-based phosphate binders, which include sucroferric oxyhydroxides and iron ferric citrate, appear to be quite potent. Well, I think it's important to keep in mind that most guidelines actually attempted to be based on clinically relevant endpoint. At this point, I'm not aware of any study that looked at the effect of iron-based binders on clinical relevant endpoints, but I think one can state indeed that the phosphate binding potency appears to be quite good. But there is currently no position of this specific novel binder in the guideline.
Yeah, that's correct, Marc. I think that you're absolutely right. The guidelines do not comment on specific benefits or harms with individual binders, other than the data on sevelamer versus calcium that we showed. So I think I agree with what you said. Ferric citrate and PA21 both appear to be effective phosphate binders and seem reasonable choices, given that the guideline update, which does suggest restricting the use of calcium-based phosphate binders.
Yep. So I'm actually very happy to see the large number of questions that pop up. So apparently this is an important topic, but I want to select one which is very important, and I want you to answer this first, if you will, Jeff. And this is about a recommendation to minimize exogenous calcium intake. And does this also include the dietary intake of calcium, or is there a difference between calcium derived from calcium-based binders or calcium from dairy products?
Okay, your response I think will be quite important here, but let me share my opinion, which is the guideline. The work group acknowledges that providing sufficient calcium intake is important, and we simply don't have evidence to suggest what the actual upper limit of safe calcium intake is in patients with chronic kidney disease. So we debated very carefully and very thoughtfully whether or not we could put any so-called safe upper limit of calcium exposure, and unfortunately there isn't evidence to do that. So each area of the world will have to decide what they view as sort of something that goes beyond reasonable. I think for many people that threshold is somewhere between 1,200 and 1,500 milligrams per day of calcium. And as you know, spontaneous calcium intake goes down in chronic kidney disease, and most available data suggests that spontaneous calcium intake from diet is about 500 milligrams. So I think that there certainly is room for some additional calcium intake beyond the diet, but with a limit that's certainly below what's currently being administered.
Yep. So I think we come to the last question, and I do apologize for the fact that we did not be able to address all questions, and there are a lot of very good questions remaining, but one might be actually really important, which is what to do if the calcimimetics are not available in underdeveloped countries. If you allow me to kick off this one, well, it is important, as Dr. Block mentioned, that there was no actual order or prioritizing of the potential treatments to treat high PTH. So in the absence of availability of calcimimetics, I think it's still reasonable to use active vitamin D, taking into account the effects of that treatment. So you have to evaluate on phosphate and calcium, of course. So do you agree, Jeff?
I absolutely agree. Yeah.
Okay. So as mentioned, there is the possibility to have your answers to the questions that have been posted to be responded to afterwards, but due to time, I think we need to wrap up now. And I really thank everybody for joining this webinar, and it's very nice to see all the attendance that there is and a lot of questions. And I give the wrap up to the central people at the central desk.
Thank you, Marc, and thank you everyone for participating. This was a very popular and lively webinar with great questions. If you still have questions, as Marc said, you can send them to the email address you see on the PowerPoint slide, education@theisn.org, and we'll make sure to forward them on to the two facilitators of this webinar today, for whom we thank for their great presentation and also moderation of this webinar. We also have recorded this webinar, so if you are interested in seeing it again for certain aspects, it will be posted and published on the ISN Academy as of next week. So thank you very much, everyone, and have a good evening, morning, afternoon, wherever you are.
Thank you. Thank you all.
Thank you.